Good afternoon again to everybody, and thank you so much for joining me on this webinar today. I'm really excited to be here. I so much look forward to meeting with you and being of help. I want you to know that I do these webinars every single Saturday, and sometimes we're off kilter because of circumstances. We have to do it during the week. When that happens, we will certainly let you know. But there's something that I really enjoy. Every week we spend a couple of hours together discussing topics that I hope will educate, inspire, and help people better understand infertility and reproductive medicine. Today we're going to focus on a subject that I believe is really one of the most important in modern IVF. How the measuring of your ovarian reserve, largely but supplemented by other tests as well, through measuring your anti-Mullerian hormone levels, AMH, helps individualize the protocols we use for ovarian stimulation. And honestly, folks, nothing, if you get down to basics, is more important than identifying the ideal protocol for a person. There's no such thing as a one-size-fits-all. For most younger women who've got normal ovarian reserve, where the AMH levels are within a normal range, they will usually respond in a predictable way to just about any protocol you use, and you'll be able to get plenty of eggs from them. But for those that have low AMH levels or high AMH levels, it's completely different, because the increase in AMH reflects changes in the hormonal environment in the ovary that affects not only the number of eggs you get from a woman, but more important than that by far is quality. It affects the quality of the eggs. So it's really important to discuss this, and today we're going to spend some time. I'm going to explain how we approach these very different situations and why choosing the right stimulation strategy can make the difference between success or failure. I'm going to say right up in front here, most of the people I see that are struggling to get good quality eggs and embryos, which is fundamental to success with IVF, most of the women that have this are because the protocols of stimulation they're on were not ideal for their circumstances. Now, of course, there are some that have got such poor reserve, such high reserve or such low reserve, they're not going to respond to anything you do. 90% plus are going to be those that could have done a lot better if the protocol chosen for them was individualized to meet their needs. And we're going to focus on that today. While that's going to be our main focus, I also want you to know that I'm willing to answer any questions on infertility, IVF, IUI, recurrent pregnancy loss, anything that affects reproduction. That's not the main topic today, but if questions arise on those issues, I'll be happy to answer them as well. So I'm going to do my best to answer as many questions as I can. When we're about 10 minutes along, Josh Bell, who's here with me again today and does most of the videography for me, will signal that there are enough people that are busy, that are engaged, and I'll go into a description of the topic today, a brief seminar to introduce the basis for further discussion. So, Josh, do you have any questions you read?
We've got a bunch here. Thank you guys so much for joining the live stream.
That's a good start.
We've got several questions already, and we're going to start answering them. We're going to answer Sophia87 on TikTok. They said, chemical pregnancies in DOR, question mark. Can you see any reason?
Well, a chemical pregnancy is nothing else but a loss of a pregnancy before you could recognize its presence by ultrasound or clinically. So a blood test tells you you're positive, but nothing else can confirm it. And after a couple of days, the blood hormone level of HCG, the pregnancy hormone, goes up, and it starts coming down, and you lose the pregnancy. So yes, if a woman's got severely diminished ovarian reserve, and we're going to talk about it, it affects the quality and quantity of her eggs. If you're able to get even one egg out of the egg retrieval, which is good, it will usually, if the man has not got a severe problem, result in an embryo that is what we call competent or euploid, that's got all 46 chromosomes present. And if you put such an embryo in about 60% of the cases, regardless of the woman's age, you'll get a healthy pregnancy. But if that embryo is abnormal, the commonest way you lose it is through a chemical pregnancy or an early loss. And the chemical pregnancy may occur so early that you never even knew you were pregnant in the first place, so you present with infertility. So whenever we see biochemical pregnancies, we've got to ask ourselves the question, did this happen because the embryo was defective, because it was abnormal chromosomally or genetically? Or did it happen because the embryo wouldn't attach, because the uterus wasn't receptive to it? This is the equation, a seed-soil relationship, a numerator and a denominator. The numerator is the seed, the embryo. The denominator is the soil, the uterine lining. You can't plant a good seed in a bad soil or a bad seed in a good soil. So if the seed is bad, and it's usually bad because it's chromosomally abnormal or aneuploid, the embryo won't attach at all, or to attach briefly and be a chemical pregnancy, or you'll miscarry. And if you're very unlucky, you'll go on and have an abnormal child, like with Down syndrome. But you need to know that a biochemical pregnancy does not point towards diminished ovarian reserve. It's not the main cause, but it can be part of the cause, because in such situations, oftentimes, the protocols used for stimulation are not optimized.
Alrighty, Jude just texted us and wanted you to know in the group chat that we just hit 13,000 followers on TikTok, and that's because of these lives so far. So thank you guys so much for getting us the 13,000 followers. That's all because of you guys. Thank you so much. We're going to continue answering questions here because there's so many in the comments right now. I'm going to answer Michelle DO910. They said 3 IUIs failed, no known problems about my health, all tests required are normal, yet I have failed.
Again, it also depends on your age, because as you're going to learn in a few minutes when I give my presentation, the older a person gets, eggs that have been in your ovaries all your life through wear and tear deteriorate. And when you're in your early 30s or earlier or younger, you'll end up having roughly 2 and 3 or 3 and 4 eggs that are available, being able to produce chromosomally normal embryos that can make babies if everything else is going your way. So yes, age is a big factor, but if you're under 35 and you're having failures with repeated IUI attempts, which by the way is a procedure I personally introduced into the field of medicine in 1984. It's now used all over the world, proudly so. It's not for everyone. There are many people it's not for, it's specifically not for. Maybe we'll get a question down the line, who's it not for, and I'll address it. But the point is that if you have IUIs and you're young and you've got normal AMH ovarian reserve, you should 3 out of 4 eggs should be normal. And if you're not getting pregnant, it's pointing towards the likelihood that the cause of your failure is not related to the seed, the embryo, but rather the soil, the uterus you're putting it into. So you need to be evaluated to see whether there's an anatomical cause, whether the lining is too thin so it won't support the roots of the embryo, or the uterus is irregular inside, it's not smooth, and these irregularities can be due to scar tissue or polyps or tumors growing into the inside of the uterine cavity that irritate the lining and eject the embryo, make it unfavorable for the embryo, or one that is so often missed. Occurs in women with endometriosis in the third of cases. It occurs in women who've got lupus or rheumatoid arthritis or hypothyroidism, personally or in their family, and that's an immunologic cause. The immune system in the uterus has got to be well arranged and organized to receive the embryo. If it's not, the embryo will be rejected. And I was one of the people that introduced this into the field. I'd like you to click on the link on my bio and go and get the 2 books that come to you free automatically. Here are examples of some of the books I've written. One of the books is on the immunology of failure to conceive with good embryos or repeated miscarriages, which are often due to these causes. And the one book is on immunology, and you'll be able to read up more about that. If we have time today, I've been over it many times in these webinars, and these webinars that I've had in the past that cover these are on Spotify, on YouTube, on Google, and on Amazon. So you can go back to at Dr. Geoffrey Sher, and you'll be able to find those webinars and watch them if you like. But the books that you'll be able to get by clicking on the link talk to all of these issues. So click on that link, go to the bio, click on that link, and you'll find it. The first one you click on, you'll get free books sent to you, and you'll be able to read up on these issues.
Awesome. Like Dr. Sher just said, in the link in our bio, you can get access to all those free resources. They're there for you. In the meantime, while you're looking at that or filling out the questionnaires, you guys can continue to listen to the questions we answer here. We were going to answer about like one or two more here, and then Dr. Sher is going to get started on his webinar today. We're almost at 100 viewers in the chat right now, so please get us up there. We're at 87 right now. Once we hit 100, we'll start today's session. I'm going to answer Chaya here. She says, what do you think about microdose Lupron for DOR? Question mark.
If you want my honest opinion, I'm dead against microdose Lupron flare protocols in anyone. And you're going to learn more about that when I do my presentation in a few minutes. Lupron expunges all the LH, luteinizing hormone, from your pituitary gland. And as you'll learn in a few moments when I go over everything with you, you want LH because it makes the ovary produce estrogen, which is the building block for the follicle to make estrogen. And if you don't make estrogen, you won't have follicles grow, you won't have the eggs develop properly. But you don't want too much LH. And if you use Lupron, which I use a lot of, you don't want to use it and start it immediately when the stimulation begins. Because it expunges, like if you squeezed a waterlogged sponge in your outstretched hand, squeezed it, all the LH hits the blood circulation, gets to the ovary, causes too much testosterone to be formed. The LH makes the ovary produce testosterone, but you don't want too much. If you overproduce it, it'll have the reverse effect. It'll compromise egg quality and therefore embryo quality. So microdose Lupron is something I stay away from. But if you use Lupron, you want to start about a week or more before the period begins. You don't want to start at the point the eggs are leaving the starting gates when you're stimulating the woman, because those eggs then become overdosed with too much ovarian testosterone. And too much testosterone produces a condition that I'll refer to later called premature luteinization, which compromises egg quality, follicle growth, and compromises outcome. So the women that really shouldn't use it, in my opinion, are women who are already putting out too much LH. And these are women that are older, over 40, women with diminished ovarian reserve, low AMH, and women with a very high AMH. And we'll be talking about those conditions in a while.
Alrighty. We're going to get started here in just a second, but as Dr. Sher said, he has multiple resources and free ebooks that are in the link in our bio. You guys can go check any of them out. There are multiple ebooks in there, and he also has exclusive articles that he writes for these live streams, exclusive to you guys today only. On the webinar, we take off that link at the end of the day, so you guys get a certain amount of time. You get 2 hours to get that link and go get all the free resources you can right now. We're going to get started. We got about 100 people in the chat. Thank you guys so much. We got tons of comments coming in.
Let me start off by introducing what you've just said, because I think it's so important. Then I'll lead into the webinar,
Perfect.
into the seminar. First of all, if you click on the first link in my bio, you'll immediately receive a copy of the article I wrote for today. An article similar to this one that I wrote for next week's one. For those of you interested in knowing what's coming next week, you can see it there. The title is Preventing IVF Failure. It's going to be a big topic. So next Saturday at 2 p.m. West Coast time and 5 p.m. East Coast time, we'll be talking on that topic. But today, the topic, as I mentioned, is on ovarian reserve. But if you click on that and you get the article, on the first link you'll get the article, but you'll also, as I told you, you'll be able to get a copy of the books that I've written. One book is 300 pages long. It comes as a free downloadable ebook. The moment you click on it, there's nothing in return. We're not asking for anything in return. All we're doing is giving you access to information. So please click on that link, get the book, every one of you. There's no reason not to. The second book you get is on the immunology of infertility and pregnancy loss. So you'll get 2 books with no solicitation, no pressure. So please, if you would, click on that. The second link is an important one. The second link you click on immediately brings up a 5-minute questionnaire. Now, I want to make it very clear. There's no pressure on anybody, but this questionnaire, you fill it in, and I suggest you do it while you're still online with me now, because it's first come, first serve. It takes 5 minutes to fill in. Easy, yes, no answers. If you fill in that questionnaire, on Monday it'll appear with my office manager, Patty Converse, on her email. She'll get it, and she will then know that you may be interested in talking to me. Many of you will realize along the way that maybe I can help you, that you have unique problems that need special attention. Patty will set you up with a consultation with me. Now, yes, it is not a free consultation, but virtually everybody who's got insurance, virtually everybody, will be able to get access to that consultation through their insurance, and Patty will help you. For those that are out of country or don't have health insurance, that'll get them on. Unfortunately, we can't help it, but bottom line is, most of you, virtually all of you, will be able to get access to me through your insurance for an hour consultation. The moment you fill in that questionnaire, I convert it into a template. We then have Patty organize and set you up with a consultation, which takes an hour. We'll talk, and upon the completion of that consultation, I'll send you a 20 to 30 page report, which explains everything we've discussed and gives you additional educational and reading materials that you can read and understand about your situation. They'll be geared towards your situation specifically. And then, upon doing that, you can then make up your own minds whether or not you have an interest in being treated by us or anywhere else. There is no pressure. All I want to do is make sure that you have knowledge and have access to what I can impart to you during that consultation. I also give all the patients I consult with my personal cell phone number. Then those patients can then reach me anytime by calling. I ask them not to email or text me, because I can answer those questions that you have in one-line answers. We need to talk. So all you do is you call, and if I'm busy, you leave your name or phone number, or your husband or partner does, on my voicemail, and you have my word. I'll call you right back. And that's forever, whether you come to me or you don't. If we do the consultation, you have access to me on questions that may come up during the course of your treatments. So my advice to you is to get on this list quickly. It's a first come, first serve. So fill in the questionnaire, even if you ultimately decide not to come to us. And Patty will reach out to you. It's up to you whether you take a call. It's up to you whether you tell her you want the consult or not. Finally, I really want you guys to help me, if you can, by spreading the word about these webinars, because the faster we grow, the sooner I'll be able to get launched into my own podcast, bringing in experts from all over the world to help talk about issues that are central to your needs. Okay, enough about that. Now, again, reminding you, next week, this is the subject: preventing IVF failure. So this is the article. I just finished writing it. That's why it's on my desk. And I'm going to give it to you for next week. I want you to understand that a woman is born with all the eggs she's ever going to have. Those eggs reside in the ovary, and when you're born, they're there. And when you start ovulating every month, you use them up in batches. The number available in each batch is genetically determined. It's not something we influence. We can't make you have more eggs available coming into play every cycle. That is genetically determined. Some women have a tremendous number of eggs. Others have fewer, and others have very few. And that is outside of our control. We don't shuffle the deck. We don't deal the hand. We deal the hand. We play the hand we dealt. The good Lord deals the hand. So when those eggs come into play, every month, one or sometimes two of them will ovulate if you're an ovulating woman. Now, if you don't ovulate, sometimes these are the typical women that make large batches of eggs. And we'll talk about that in a moment. Anyhow, the eggs that are available get used up every month. And those that are available every batch are gone. Once they're there, even if they don't ovulate, none of them ovulate, they are lost. And every month, there are fewer and fewer eggs. At a certain point in your life, and it varies from woman to woman, the number of eggs left in your ovarian bank is going to fall below a certain safety threshold. And that can vary from woman to woman when that happens. Usually it doesn't happen till the late 30s or early 40s, but I've seen it happen in women in their early 20s, and some women have got no eggs all the way through. They have a genetic problem with no eggs. But as the egg population drops below that threshold, you now move into the realm of diminished ovarian reserve. And that means that the eggs that are in little primordial follicles that are present in the ovary, those eggs are going to be the batches that will be available to you. Obviously, if your ovarian reserve falls too low, that means the number of eggs that are going to be available each month presenting themselves for use are going to get less and less. And the normal ovarian reserve used to be measured by measuring hormones called FSH and LH. Today we measure them through measuring a hormone called AMH, anti-Mullerian hormone, which is formed by the same cells in the follicle that also produce estrogen, called granulosa cells. So when the AMH level is low, it tells you there are less of those granulosa cells, and presumably therefore less follicles available in each cycle. Now, the lower the AMH, the fewer eggs are going to be presented each month. The normal AMH is over 1.5. If it's over 2, you're in great shape. 1.5 to 2 is a grey zone, and when it drops below 2, it's simply telling you, be aware it's on the downward slope. It's time to be proactive. Don't dilly-dally, because things can drop real fast. When it drops under 1.5, now you've got diminishing reserve. If it's under 1, it's quite severe. And if it's under 0.5, it's very severe. And if it's under 0.1 or 0.2, you're imminently premenopausal. There are hardly any eggs left. So measuring the AMH gives us an idea of how many eggs are going to be present. Now understand this. The AMH measures how many eggs will be available in a cycle. But if it's diminished, it usually points towards hormonal changes in the ovary. Hormonal changes that are associated with increased production by the ovary of the male hormone testosterone. Other hormones, male hormones, are androstenedione, dihydroepiandrosterone. They're also produced in the tissue surrounding the follicle. We call it the stroma. And this testosterone, male hormone, is carried like in a bucket brigade to the cells that lie in the follicle inside. Where, and this is important, under the effect of the hormone FSH, and that name will ring a bell to you. FSH is the hormone that we give by injection to make you produce follicles. FSH is also produced on your own. All males and females produce FSH. So the FSH converts the testosterone that's carried to the cells of the follicle into estrogen. Blood estrogen levels go up, the follicle enlarges, and the egg develops. Simply stated, you've got to have some testosterone in order to make estrogen, to make follicles grow and eggs develop. So what makes the ovary produce testosterone? It's mainly the hormone, which is the sister hormone of FSH, also produced in the pituitary, and also present in certain fertility drugs, called LH, or luteinizing hormone. Remember the name luteinizing hormone, because the luteinizing hormone, if it's produced in excess, will make the ovaries overproduce testosterone, which will get into the fluid of the follicle and now have the reversed effect. We believe that it switches off the ability of FSH to convert the testosterone to estrogen and make follicles grow, which is why the follicles stop growing, the eggs don't develop properly, and you get the estrogen blood levels not rising like they should. We call this, therefore, premature luteinization. Premature luteinization means overproduction of LH-induced testosterone, which compromises egg development and follicle growth. Now, in human biology, if any particular organism or structure doesn't develop normally, it usually won't ripen, or it won't ripen properly. And the same happens with an egg. If it doesn't develop properly because it's overexposed to ovarian testosterone, and in my opinion, premature luteinization is at the root of it, you will end up with eggs that didn't develop properly. And if you try to ripen them by giving HCG, a trigger, or even in nature, if LH is released on its own, which you measure in the urine in the middle of the cycle to see if you're about to ovulate, HCG is an analog of LH. What they both do is they send the eggs into what we call meiosis, which is called reproductive division, which rearranges the chromosomes to make the eggs able to be fertilized by the sperm if it's normal, and produce healthy, competent embryos that can make babies. So it's very, very important that the egg develop properly, so that when the HCG or the LH exposure occurs, the egg will go through orderly meiosis and be what we call euploid, have exactly the right number of chromosomes, so when fertilized by the sperm and it adds its chromosomes to the egg's chromosomes, now you end up with an embryo that's euploid, which has got to have exactly 46 chromosomes. If it's got even one more or one less, it's referred to as being aneuploid or incompetent, and such embryos almost always the result of poor quality eggs. Can be the sperm, but almost always it's due to the egg not being developed properly. You will end up with an aneuploid embryo, and such embryos, if they fertilize, usually will not attach, or they'll attach briefly, and you won't even know you were pregnant, or they'll attach and cause a biochemical pregnancy, which we spoke about right at the beginning of the session, or it will result in a miscarriage, and worse still, cause defective development of the baby. So for all of those reasons, we've got to have normal eggs. To have normal eggs, we have to have normal hormonal environment in the ovary during stimulation. Women with diminished ovarian reserve overproduce LH in the pituitary gland. And in my opinion, that's the most important reason why women with diminished ovarian reserve are much more likely, listen very carefully, much more likely to have poorly developed eggs, aneuploid embryos, more than you'd ordinarily expect for their age. And there's an increased incidence of that just simply because of wear and tear on eggs that have been in your ovaries all your life as you get older, but this adds to the problem. So it's really important to bear in mind that we cannot put the toothpaste back in the tube. We cannot make you younger, so there's less corruption of egg development and more eggs developing. We can't make your ovarian reserve reverse. Can't be done. All we can do is rescue those eggs that enter into the cycle that have the potential to be normal genetically, and keep them on the tracks by keeping LH-induced testosterone at a tolerable level. There's got to be some testosterone, therefore some LH, but not too much. You want to avoid premature luteinization, and that's done by individualizing the protocol for ovarian stimulation. And I'm sending you articles, and I'm sending you books that explain this to you in detail. Again, there's nobody present today who shouldn't go there. Click on my bio and click on the link to get the free books and the free articles on this particular topic, given to you without any requests, without anything in return, automatically arrive on your email so you can read them and understand this. Because individualizing the protocol is the most important way to help women that are getting older, and therefore have got too much LH-induced testosterone, and women that have diminished ovarian reserve to get at least one good or more than one good egg that will make a good embryo in the right lab done properly. Again, the embryo's got to be good to make a baby, and the events that even precede your doing IVF will determine the likelihood of that happening, the most important of which is your ovarian reserve as measured by AMH and your age. And we can change those. We can only alter the environment to protect the eggs and give you the best chance of getting a good embryo. Because if the embryo we put in the uterus, which we've tested by doing a procedure that Dr. Drew Tortoriello, my partner, and I developed 20 years ago and is now used all over the world, very proudly so, it's a game changer, called PGTA. If it's tested and is normal and is put into a uterus that is receptive anatomically and immunologically, and the person doing the transfer is expert and a good gardener, so it plants the seed in the right place in the right season with proper support, your chance of having a baby should be 60%, regardless of age. Now, because older women are far less likely to have normal eggs because of wear and tear on the eggs, pregnancy potential goes down with age, and it's harder to even find an egg that is normal in a woman of 45, where only 1 in 30 is normal, as compared to a woman of 33, where 3 in 4 may be normal. Obviously, the chances of success are less, but once you do find the right embryo, you can compensate for that problem, and that's why repeated IVFs with banking good embryos is the way to go if you insist upon trying with your own eggs. Now, the second group of women are not the women with diminished ovarian reserve. These are women who genetically, because of a predisposition, enter into the period of eggs being recruited for a cycle ahead of them, where very large numbers of eggs are available. These are women, therefore, who have higher AMH, because there's more granulosa cells forming the AMH. These are women who've got increased ovarian reserve, IOR. This article I'm giving you explains it. And the condition that commonly does this, one we often see in women, are women who are not ovulating on their own normally. Women who don't have regular periods or have no periods at all. These are women with hypothalamic causes of reduced FSH and LH production, which you can pick up by testing their blood. But there's a specific condition which used to be called PCOS, polycystic ovarian syndrome. Today we call it polyendocrine metabolic ovarian syndrome, or PMOS. PMOS is a condition which is renamed for good reason. First of all, the word polyendocrine points towards or recognizes the involvement of multiple hormonal systems in the process. The metabolic highlights the role of insulin, high insulin levels, women who are pre-diabetic and have other metabolic dysfunctions that go along with this condition. And the ovarian points to the fact that it's present in the ovaries, and you see the cysts. And syndrome it points to the fact that the condition can present in many different ways. So the new name PMOS, polyendocrine metabolic ovarian syndrome, another name for PCOS, is one where there are very large numbers of these little follicles in every month. And now, the typical feature of this condition is also women that overproduce LH. Ordinarily, in the normal situation, the woman will have a higher FSH than LH. But with PMOS, the LH is often higher. And for what I've told you, now you've got lots of follicles developing in the ovary, and now you've got too much LH, so that these follicles grow in response to stimulation. These women tend to be very responsive to stimulation, overproducing a large number of follicles, but they also overproduce LH, and that often means that the quality of the eggs is again compromised through premature luteinization. There are ways to treat this. About 20 years ago, I developed an approach called prolonged coasting. If we have time today, I'll talk about that, but I don't want to go into too much detail here. prolonged coasting allows us to protect the eggs in the cycle, protect them from overexposure to LH, avoid all the serious life-endangering risks associated with overstimulating women with PMOS and ending up with life-endangering situations, and still getting good quality eggs. I will, if we have time, talk about it, but if we don't have time, I urge you to read the article I've written for you and to go into the book that I'm giving to you free of charge and read up on ovarian hyperstimulation syndrome. It explains it there in detail. Very importantly, you make lots of eggs, but there's another problem that occurs with this overstimulation and over-response. The doctor gets concerned that so many follicles are developing that the woman's going into a severe danger zone of getting severely overstimulated. So the doctor stops the cycle early to prevent those follicles growing too much. And these follicles that grow and overgrow often also produce toxic vascular substances called VEGF, which cause the condition of OHSS. And the doctor wants to stop that, so he cuts the cycle short by triggering the woman early. There's a problem with that. The problem is you're taking the fruit off the tree before it's ready to be plucked off the tree and ripened. It's too soon. The egg isn't ready to have been forced into meiosis. And if you force it in too early, you get a much higher incidence of abnormalities of the egg, which lead to aneuploidy of the embryo and poor results. So PMOS is not only associated with poor quality eggs, it's associated with severe ovarian hyperstimulation syndrome, which with the proper treatment can be avoided and prevented all the way along the line, trying to focus on keeping LH at a low level and not allowing the woman to get into the danger zone clinically. Now, we could talk much longer. A lot more is in the article I gave you, and there's a lot more in the books that I've given you. So please go and get those books, every one of you. And for those of you who feel you're already in this risk because you fall in the realm of women who have got diminished ovarian reserve or increased ovarian reserve where the AMH is sitting above 3.5 nanograms per milliliter, you need to be focusing very heavily on maybe thinking about talking to me. And if you do, the way to get access to, for you and I to have a consultation is to do it quickly, because first come, first serve. I want you to click on the second link, fill in the questionnaire. Patty will get back to you and set you up with an online consultation where we'll have a detailed discussion about your specific circumstances. The main focus is on how do we stimulate you safely, protect your eggs, get the best quality embryos, and get you from infertility to family in the safest and easiest possible way.
Alrighty, let's get started. Thank you guys so much for commenting and waiting there as you listen to Dr. Sher's presentation. I see a bunch of push notifications coming through, so thank you guys. Go enjoy those articles and books while you get the chance. We've got about an hour and a half left of our time today, so you guys get that chance left to get that ebook and those articles. At the end of that 1 hour and 30 minutes here, we will get rid of the link for the articles. The books will still be up there. You can get those at any time during the week, but the articles, unfortunately, we get rid of those at the end of today's live session. So go get those while you can. They're up there right now. Dr. Sher spends lots of time and effort into putting a numerous amount of detail in there for you guys, so there's no reason why you shouldn't go get it. I'm going to answer M, because they've been loyally commenting a question for a little over 30 minutes now. So M on TikTok, our #1 viewer today, says, what surgery would you recommend for dermoid cyst and endo? Also, would you recommend Vitex and CoQ10?
CoQ10 and Vitex are fine. Whether they help or not, I can't tell you. Nobody knows for sure. They won't do harm, and they can be of benefit. But let's focus on what you spoke about, the dermoid.
Yes.
A dermoid cyst is a tumor. It's formed because one of the eggs fertilized on its own. It's called a germ cell tumor. And because it contains components that would ordinarily develop into different parts of the body, these tumors have got tissues from all different parts of the body: lung tissue, skin, sebaceous glands, brain tissue. I've even seen penile tissue, gastric mucosa, anything you can think of, because it comes from an egg that went wrong and started dividing as if it was fertilized when it wasn't. So for that reason, dermoid cysts contain lots of different tissues. If they are there, they act like what we call misfit tumors. They irritate the ovary to overproduce testosterone in that ovary that's affected by the tumor. And that ovary is therefore not the other one, more likely to produce abnormal eggs, which will be aneuploid after stimulation. But there's a far more important reason than just getting good egg quality to remove it. The reason is that these dermoid tumors can go malignant. Any of the tissues I've mentioned can go malignant in the ovary. In about 10% of cases, they will go malignant. So it's really important to remove them. If a woman's already pregnant with a dermoid cyst or tumor, also known as a benign cystic teratoma, if she's got that tumor in her ovary and she's pregnant already, very often we'll wait till after the baby's born. But that's a calculated risk. In my opinion, a dermoid tumor that's growing, especially if it's growing quickly and rapidly, needs to come out at least 6 weeks before you go into a cycle for ovarian stimulation for IVF. Those who tell you we'll just watch it, well, they're gambling with your well-being. I don't agree with it. I think the dermoid, especially if it's over 2 centimeters in size, needs to come out. The second question that you asked is, what about endometriosis? Am I correct?
Yes, surgery recommended for dermoid, cyst, and endo. Also, would you recommend by texting CoQ10?
Endometriosis doesn't require surgery because of the endometriosis any longer. We have just introduced a method. I introduced it some 15 years ago. It's known as sclerotherapy. If there's an endometriotic cyst in the ovary with endometrial old blood that's decomposed, we used to do surgery to open the woman and take out the cyst or ablate the cyst. The problem is you'd often remove a lot of egg-bearing tissue in the ovary and reduce the woman's ability to produce eggs. Number one. Number two, it is a surgical procedure. It's painful, it's expensive, it required an invasive approach. Today we don't need that for endometriomas anymore. That's got nothing to do with the dermoid, it's got to come out. But if there's an endometriotic cyst, you don't need surgery. You can do sclerotherapy. I gave a talk on sclerotherapy a little while ago, a couple of weeks ago, you can find it. But I'm going to do another presentation on endometriosis with sclerotherapy on Thursday, the 6th of July at 4:30 West Coast time, 7:30 East Coast time, which will be focused purely on ovarian endometriomas, ovarian endometriotic cysts, and sclerotherapy, which is an outpatient procedure, doesn't require invasiveness, it's less expensive, it's ambulatory, you get in and out under sedation, and it works equally well, very effective, and it doesn't remove any ovarian tissue. I'm not going to go into the detail of it now, there just isn't the time to spend. Go back and look at a previous webinar I did on endometriosis on Spotify or YouTube, or not this coming Saturday where I'm speaking about preventing IVF failure, but go to the one that I'm going to be talking about on the 6th of July, and we'll be talking about sclerotherapy. Sclerotherapy is a game changer. There's rarely, if ever, an indication to do surgery, infertility surgery, for endometriosis any longer with the advent of this game changer. And we have a clinic in New York at Sher Fertility Solutions in Midtown, where Dr. Ravi Kumar runs the sclerotherapy clinic over there. And we can help get you in to get this done as an outpatient, get rid of the problem, and go on and do IVF without needing surgery any longer for endometriosis.
All right, perfect. I'm going to answer Whitney Franco real quick because it's along the topic that you just were talking about. It says, if endo is outside of the uterus, why does it affect implantation?
The reason for that is that a third of women with endometriosis have an immunologic problem in the uterus. I was the first to show this in the late 80s, early 90s. You can read the thin book. I give you 2 books free by going onto my bio. Click on the link and get the 2 books. The one book is the thin one. It's the other one's 300 pages long, but the thin one, the first 2 chapters explain that there's an immunologic condition that occurs in women with endometriosis, where there's activation, overproduction of toxins called cytokines by immune cells in the uterine lining called natural killer cells. If you've got endometriosis, you have a 1 in 3 chance that that's present. And if that's the case, the embryo may be the best embryo in the world. Once it tries to attach to the wall of the uterus, these type 1 cytokines attack the roots of the embryo, destroy it, and the embryo is lost, causing failure or dysfunctional implantation. Today we can solve that problem. I have a woman with an immunologic problem similar to this that I spoke to in Australia when I was lecturing there. She was 42 with severely diminished ovarian reserve. AMH was 0.2, and she had an autoimmune condition called Hashimoto's disease, thyroid deficiency, where there's a 50-50 chance of natural killer cells overproducing these toxins. She came to the United States. I was able to use an individualized protocol for stimulation that protected her eggs, and then put 1 embryo in it that was normal, and I'm now the proud godfather of her son.
Awesome. Let me go back up here. There's someone who's been commenting for a minute. I wanted to get their question answered. Flower Garden, if you're still here in the chat, we're going to answer your question right now. It says, I am 44. I did IUI and had 2 miscarriages back to back. Should I keep going? Maybe a miracle will happen.
If you go to Google tonight, type in intrauterine insemination, put my name next to it, you'll see I was the person to introduce IUI to the field back in 1984, I believe. I've written books, I've traveled all over the world talking about it. It's a great procedure. But IUI should never be done in women over 40. Why? The chance of pregnancy is so low. It's less than 1 in 40. And if you're 44, it's less than 1 in 100 of getting a viable pregnancy. And the reason is that the eggs in women as they get older, as I mentioned earlier, are so far more likely to be aneuploid. And you make so few eggs that your chances of getting a good egg fertilized are so diminished that you can be unsuccessful. You want to take advantage of whatever time you've got left. Get as many eggs as you can through IVF, using a very individualized protocol because of your age and your diminished ovarian reserve, something I alluded to earlier on. And then get the embryos, fertilize them, do PGTA to see which ones are normal, and then start banking the normal ones, stockpiling them to make hay while the sun shines, and then put back 1 embryo at a time, remembering what I told you. If the embryo you put back is euploid and competent, has all 46 chromosomes, it'll propagate a viable pregnancy 60% of the time, regardless of your age. The odds you'll get one at 44 are remote, but it's your only hope if you want to go with your own eggs. Otherwise, no question, the most advisable approach is to get eggs from an egg bank or from a donor where you know you're getting eggs that 2 and 3 or 3 and 4 times are going to be normal because the donor was young. So for that reason, I think that you need to consider your options. Either stop and adopt, or do egg donation, which gives the highest success rate over the shortest period of time, or go in and have a shot at getting your own eggs using a very individualized approach, which is the subject of this entire presentation today, needed because of age and diminished reserve. You will then have the only shot at us finding an egg which is good, and a good one, if you find it and it makes a good quality embryo, can still give you a baby.
All right, I'm going to answer this commenter here, Lane, sorry if I said that wrong. 12 miscarriages, no live birth, all tests are normal, tried blood thinners, tried progesterone. Any advice for her?
Almost certainly you've got an implantation problem. Almost certainly. And you can keep on doing the same thing over and over and over again till the cows come home, hoping you'll have a different result. But that is the most crazy thing to consider. If you keep doing the same thing over and over, you're going to have the same result. I told at the beginning of this presentation, to get pregnant and have a baby, two things have to be working. One, the seed you plant, the embryo, must be healthy and normal. And that's the subject of this particular presentation today. But that's not all there is to it. The soil that you plant it in, the uterus, has to be receptive. And if you keep putting in embryos that reach blastocysts, especially if those have been tested and found to be PGTA normal, chromosomally euploid, and you don't get pregnant or you keep losing the pregnancies, the likelihood is that you've got an immunologic implantation dysfunction. Get those two books by clicking on the bio link. It'll download automatically. Read the thin book, the first two chapters. In my opinion, the likelihood is not only that you have got an implantation dysfunction, which could well be immunologic. It could also be because the scarring in the uterus has damaged the uterine lining, or it could be that you have scar tissue in the uterus that has formed and irritates the uterus and evicts the embryo. But the common one is going to be immunologic in your case. And if it's immunologic, it's usually what we refer to, and write this down, we refer to as being alloimmune, A-L-L-O immune, A-L-L-O-I-M-M-U-N-E, implantation dysfunction. In contrast with the common one, which is known as autoimmune, which I've alluded to earlier on. If you read that thin book, you'll find out. And in your case, I'm not soliciting you, believe me, but I really think you could benefit from talking to me. I think you should pick up the phone or go to the link, the second one, click on it, download the questionnaire, fill it in right here and now to get in line quickly, fill in all the answers, yes or no, and then Patty will reach out to you on Monday or Tuesday to set you up with a consultation with me, and we'll spend an hour together. After which I'll give you a full dissertation and I'll give you lots of information in writing to support it. And I may be the one that's able to help you go from your problem to a family.
Alrighty. I'm going to answer Karina Lopez on TikTok. They said, can you still get pregnant if you treat thyroid hormones? And sorry, I just got to open it back up. And how long will it take? I want to do IVF.
If you've got thyroid deficiency or excessive thyroid hormone, you can take medication that will regulate your thyroid hormone production. But in my considered opinion, that's not going to help you get pregnant. The reason most people, even when they treated for their thyroid condition, are unable, or many of them are still unable to get pregnant, is that 50% of the time there'll be an underlying immunologic cause for their thyroid deficiency or increased thyroid hormone production with Graves' disease or thyrotoxicosis. If you've got thyroid antibodies, thyroglobulin antibodies or TPO antibodies, there's a 50-50 chance you'll have natural killer cells in your uterine lining that are overproducing the toxins I spoke about, are produced in a third of women with endometriosis, and you won't get pregnant. So simply dealing with a thyroid hormonal deficiency or excess may make you healthy and not be at risk, but you may still not get pregnant. You need to be properly tested. There are only 3 or 4 labs in North America that can do the tests necessary that you need to tell if you've got this immunologic problem. You can't go to your regular local lab, as much as they may do a good job. They don't have the wherewithal to do these tests with sufficient sensitivity or specificity. You need a reproductive immunology reference laboratory, which we can send you to and arrange for you to be tested. Again, as I told the previous lady, perhaps you should consider clicking on the second link, filling in that questionnaire that gets Patty to call you and set you up with a consultation. Again, you are not pressured. Patty's not going to put you under solicitous pressure. She's simply going to offer it to you. And if you don't want to, have a consultation with me for whatever reason, that is your prerogative and your choice. But you should take advantage, because at the end of the day, if you keep doing the same thing over again, you mustn't expect a different result.
All right, you're going to answer Kelsey Allen on TikTok. She says, will a ferritin of 9 cause miscarriages? All tests came back normal. Supplement of progesterone, 200 milligrams.
No, I do not believe so. And if you're miscarrying, there's usually a different reason. The commonest cause of miscarriage is an abnormal egg that's aneuploid, that produces an aneuploid embryo, and is more common in older women or women who've got certain chromosomal inherent defects, or women with a very severely diminished reserve who are placed on an inappropriate protocol. But it can also occur because of an implantation problem where there's an immune issue in the uterine lining, or there is an anatomical reason that the uterus won't accommodate the implanting embryo.
She says only 28 all chromosome tests came back normal.
You've got an implantation problem. Either there's scarring in the uterus, or you've got little polyps, like little mushrooms growing into the uterus, or you've got fibroid tumors in the wall of the uterus protruding into the cavity, or you've got a thin lining that's persistently under 8 millimeters, or you've got an immune issue. There are others as well, but that is 80% of the time what it's going to be. For you, I think we should talk. Fill in that questionnaire, go to the bio, click, and if you change your mind along the way, no pressure. But at least get yourself in line so we can talk.
KDX96 on TikTok says, is there something I can do to have better quality eggs? I have DOR and 4 failed IVF.
Well, this is the subject of our discussion today. Again, depending on your age, if you've got diminished ovarian reserve, I'm sure if you heard what I said earlier, you already know the answer. You need a protocol that doesn't overexpose your developing follicles to too much LH-induced male hormones such as testosterone. What I would use is a protocol that I've developed 15, 20 years ago called the agonist-antagonist conversion protocol, AACP. You'll find it in this book of mine that we'll be sending you. If you go and you click on the link in the bio, the agonist-antagonist protocol involves starting you on a birth control pill which immediately suppresses your LH and gives your ovaries a breather to keep the LH low. Then, while you're still on the birth control pill, we overlap the pill with a GnRH agonist like Lupron, Buserelin, Decapeptyl, aminopeptidyl, Triptyline. We overlap you with that for 3 days and give you human growth hormone to augment mitochondrial activity in the egg, we hope. So all 3 together for 3 days, then we stop the pill. You continue taking the injections of Lupron every day, or Buserelin of the agonist, and then you continue also with the growth hormone, and within a week or so you have a period. The moment you have your period, we get your blood tested to see that the estradiol level is at baseline and you're ready to start. We do an ultrasound to make sure there are no cysts in your ovaries. If everything's a green light, now we switch you from the agonist, which is the Triptyline, the Lupron, the Buserelin, to a drug called ganirelix, cetrotide, or orgalutron. These are antagonists, hence the name agonist-antagonist conversion. And we don't start you on the 6th or 8th day of your stimulation, because if we wait 6 or 8 days to start you, the LH that could very well be elevated in you because of your diminished ovarian reserve could kick up again, cause increased testosterone production in the ovary, and we're back in trouble. So we start you on the fertility drugs on the very first day we start the antagonist. And now you go on to a high dosage, depending upon what your AMH is, of purified FSH with a very small amount of Menopure, which is a minotropin. Menopure, unlike Follistim, Gonlef, or Purigon, contains equal amounts of FSH and LH. So you don't want to give too much Menopure to women with diminished ovarian reserve, because then you create a problem by overexposing your ovaries to too much LH-induced testosterone. So we use only up to 75 units of menopure added. You continue on the stimulation. You do all this at home, no matter where you live. And by the way, my patients come from over 70 different countries. And then you arrive in New York when you're 7 or 8 or 9 days into the protocol. We work with your own OBGYN to get everything done at home. And I start doing the monitoring on you daily by ultrasound and estradiol. And as soon as everything is ready based upon the size of the follicles and the estrogen level and that the two correlate, I trigger you with HCG, which is either Pregnal, Profaci, or Novarel, or I give you recombinant HCG called Ovidrel. If you use Ovidrel, you've got to give 500 micrograms, which is 2 vials. If you use HCG, you've got to give 10,000 units. And then we bring you and do an egg retrieval 36 hours later. When you're asleep, while you're asleep at no extra cost, we look inside your uterus to make sure there's no surface lesions or polyps or fibroids or scarring. And if there is, with your permission in advance, we can deal with it while you're asleep. When you wake up, it's all done. When you wake up, we tell you how many eggs we got, what their quality looks like under the microscope, what your uterus is like, how thick your lining was. And then you go home immediately the next day. We stay in touch with you, let you know after getting sperm from your husband. And he only has to be there on the day of the egg retrieval. We inject 1 sperm into each egg. It's called ICSI. The eggs divide, keep on dividing. We follow them, and when they reach the point of reaching the advanced stage of development called blastocyst, where there are over 100 cells, and they get there by no longer than 6 days of development, we biopsy them for PGTA, and then we have that discussion when the results come back 12 days later. I want to just mention, for those of you that don't know, if you go to the website, or if you go to the internet and you type in PGTA, you'll see that Dr. Tortoriello and I introduced PGTA into the field of medicine some 20 years ago. It's now proudly used all over the world. It's a wonderful breakthrough and a game changer, but it doesn't make better eggs or embryos. It only helps you identify the good ones. And if you put the right one into a uterus that is well receptive or rendered such, medically you should be successful in having a baby in the right hands.
Perfect. As Dr. Sher just said, there are plenty of resources in the link in our bio. And those of you who have been here for our past live streams, you guys know that we will only be live for another hour here of today's session. And in that hour is the only hour that you can get the access to the exclusive article that he wrote for you guys today. So go check that out while you can. You guys can still listen in on the TikTok and be a part of the conversation here and listen to the questions getting answered and fill it in at the same time. So go check that out. The link is in our bio. Fill out a 4-minute questionnaire and get access to literally everything there for you. We're going to go down here and answer, I don't want to pronounce this wrong, it says LYD on TikTok. They're the number 2 viewer currently. They said, 36 years old, I have an AMH of 1.2 FSH, is now 9, but estrogen is sub 30. What are my options?
You're quite well off. You're young enough to make good eggs still, provided the protocol is properly used. Yes, you're developing diminished ovarian reserve, and things can go downhill real fast. So at this stage, it's time to be proactive. Don't do IUI. You're wasting valuable time for very poor results. You need IVF. And I would tell you if IUI would work, because I'm proud of the fact that I developed and introduced IUI. But it's not for you. And a 1.2 AMH today could be a 0.2 in a year. Don't wait for that disaster, because you can't reverse the clock. So you need IVF, and you need to use an individualized approach to ovarian stimulation, which is the main thrust of this discussion today. I can't emphasize it enough. You also will require the AACP protocol, the agonist-antagonist conversion protocol, which you will find in the books and the literature that we provide to you through our bio. All you got to do is click on the links. And if you want to discuss it with me, I'll be more than happy to do it. All you got to do is fill in that questionnaire by clicking on the second link, and that questionnaire can be filled in while you're waiting. I recommend to people who are busy, who's with us, fill it in now. You can decide later whether you want to go forward, but at least you're in line and it's first come, first serve. Fill it in. It will reach Patty. She'll reach out to you and she'll bring you to have a consultation online with me for an hour, at which point I will be permanently linked to you. I will be there for advice if you ever call me, whether you come to me or not, or I will be there to treat you if you want me to.
It looks like we have one of your clients in the chat right now. They said, Andrea is, I am 41 and 28 weeks pregnant after my first transfer with Dr. Sher. Can't wait or recommend enough.
Thank you, Andrea. Thank you so much.
Awesome. Always love to see clients in the chat here. Let's go up here.
I wish you well, Andrea. Hope things go well for you. You've got my email. All my patients get my email. So when things go well for you and you've had a baby, send me a picture, put it in my album, and let me be in contact with you and wish you well.
Awesome. That's so awesome. Elena Suffer on TikTok says, how do you feel about a day 3 fresh transfer when someone doesn't have that many embryos left?
The biggest mistake people make is believing, listen very carefully, that by putting an embryo in the uterus earlier, you're getting it into a natural environment and safer in the uterus than in the petri dish. I used to believe that 20 years ago. No longer. We now know from concrete data and proof that an embryo that won't make it to a blastocyst, the most advanced stage of development in the petri dish, will not make it in the uterus either. If you get pregnant, it would have made a blastocyst in the petri dish and you would have gotten pregnant as well. The downside of putting the embryo in earlier, it's not that it won't be just as likely to make a baby if it's normal, it's that you won't know if it can. You won't have any idea of where you're headed no matter how it looks. We used to rest a lot of attention on the microscopic appearance of the embryo. It's not nearly as important as its chromosomal integrity. So my advice in this day and age is don't put embryos in unless they make a blastocyst. If they don't make the blastocyst in the laboratory, they wouldn't have made a baby in your uterus anyway. And at least you know what to do. You know what your options are. You know whether to try again or to bank the embryo and try to bank up more of them over time to build up an inventory for future use. In my opinion, while you can put back embryos even on day 2, not on day 3, you're far better off going to blastocyst. Unless this is a shot in the dark, you're trying once, you're never going to try again, then you may as well put whatever you've got back and hope for the best. But otherwise, it's like going duck hunting and taking a pot shot at where you hear the quacking instead of taking aim at the duck. You're not going to have a roast duck dinner.
All right, I'm going to answer. Let's answer this one first real quick. Manhead, I'm not going to be able to pronounce that. I'm so sorry. Sid359 says, Doctor, where are you located?
Our clinic is in Midtown Manhattan on 38th and 5th. We have 3 doctors working there. Dr. Drew Tortoriello, the medical director who's been a partner of mine for 20 years, is unquestionably one of the finest reproductive endocrinologists in the world. If my daughter needed IVF, Drew would be doing it. The other one, very accomplished, is Dr. Sitara Ravikumar. She is wonderful. She's been with us a few years. She's excellent. And she runs our sclerotherapy clinic for the non-invasive, non-surgical treatment of ovarian endometriotic cysts, which I'm going to be talking about in the next few weeks. And then myself. And we work interchangeably. Believe me when I tell you it doesn't matter who does the hands-on. We all do things the same. It's the protocols, the procedures, and the implementation. And if I am your doctor, I will be overseeing your cycles. Whether I do the actual hands-on egg retrieval and transfer or not is not relevant. I may, but it could equally be any of the other doctors. So that's not the issue. The issue is to get into our system, to have the right approach, the right protocols, the right implementation.
I just want to read another cool comment here. Vanessa Silva on TikTok says, I just want to say thank you. I chose medicated cycle because of your advice. Tested positive today! !
Congratulations.
Awesome.
She used a medicated cycle for frozen embryo transfer because I told her, I remember telling her, in my opinion, it's the best way to go for a variety of reasons. I could go into it now, but I don't think I have time. But using natural cycle FETs or using FETs with a modified natural cycle, I don't think is the right way to go. You want to use hormonal preparation. It gives you a much more assured window of implantation when the embryo is more likely to take.
All right, I'm going to answer some more questions
in
here.
my opinion.
Thank you guys so much for these great questions. I see also people pushing more push notifications coming in for the questionnaire and the ebooks. Thank you guys for filling that out. That is awesome. We love to see that. For those of you who might just have joined or don't know already, we have free ebooks, free articles, and exclusive articles that are on the link in our bio right now that Dr. Sher has written himself. And the exclusive articles are based on today's topic. He writes a new one every Saturday for you guys, or every time we go live, there's a new article exclusive for the viewers of today. So go check that out. If you're in here, you're one of a kind that gets the access to that that article. Other people will never see it again.
And again, next week on Saturday, this is an extremely important topic. Can you see it?
Perfect, right there.
It's called Preventing IVF Failure. Preventing IVF Failure. I finished writing the article, which is why it's still on my desk. I just finished today. You'll get this article at the next week webinar. Please spread the word around. Those of you that are in chat groups, get the word out there for us. The more people that we get to these webinars, the sooner we'll be able to launch into the development of our own podcast.
Absolutely, absolutely. And as you guys just saw there, it's not just one page that Dr. Sher writes. He hand writes all of this. It can be anywhere from 2 pages to 15 to 20 pages at sometimes. So please go check that out. They can have so much information in there, especially on these topics that are, harder to find or you have to dig a lot of research for. Dr. Sher is just handing it to you guys for free. All you do is fill out a 4-minute questionnaire and you get access to everything we have. So go check that out. Link is in the bio. We're going to answer some more questions with the last little bit of time. We will only be live for about 40 more minutes, so go check the live or go check the link out. We're going to answer some more questions with the next 30 minutes of our time here, though. Keep commenting. I love all the comments here, and thank you so much. I see more push notifications coming through for the books. Alrighty, let's go down here. Okay, the girl making vids says, what? With diminished ovarian reserve, will I hit menopause early? ?
In all probability, yes, which is one of the reasons you got to move quicker. Because it's not only hitting menopause, it's what happened in the ovary as the ovarian reserve declines, altering the quality of eggs. Most people think IVF is just about getting as many eggs as possible, fertilizing as many as you can and putting them in the uterus. That's a sure way to failure. That'll only work in a woman who's young with normal ovarian reserve. But if you've got increased ovarian reserve, as with PMOS, or you've got diminished ovarian reserve, you are in trouble if you just take that approach. So yes, things are going to get worse as time moves on.
Amac on TikTok says, a rely on 42, AMH 80.84, doing IUI, can't afford IVF, need advice. Thank you.
The best advice I can give you is don't waste your time with IUI. Your chance of getting pregnant at your age and having a baby with IUI, even though I introduced IUI into the field, is 1 in 40 or less. You need IVF. Save your money, save your emotion, and do what works. Don't do that which doesn't work. IUI is going to lead you from infertility to futility. Do not do what's not going to work, in my opinion. Now, I can be wrong, and my wife will tell you I'm wrong many times. But the truth of the matter is, that's the best advice I can give you.
Listen to your wife. Hi, this is Lovina Love on TikTok says, hi, can an AMH of 0.08 ng still have a successful IVF? Thank you.
Yes, but it's very much less likely because you're premenopausal. If we get a couple of eggs, it depends on your age, depends upon how we stimulate you. And if we get our hands on an egg that is normal, it'll behave as if you made 20 of them. Problem is, it's not likely to happen. The lower your AMH, the fewer eggs, and the older you get. So one thing you don't have to just rest your laurels on is time. You've got to move. In all probability, you're heading towards adoption, stopping, or using an egg donor. But if you want to try, you better try yesterday. We've got to really move. And again, I think we should talk. I think you should fill in the questionnaire. Whether you end up talking to me or not, get in line so we can call you up in the order at which people fill in that questionnaire and maybe help you through some of your issues.
UK on TikTok says, does FSH of 22 in a man with low automatically mean infertility? Jesus.
An FSH of 22 in a man with sperm problems is bad news. The FSH goes up above 12, there is suppression of sperm production. So at 22, I wouldn't be surprised if there's hardly any sperm. But that doesn't mean that if there are sperm, we can't fertilize the eggs, because there's the DNA in the sperm's head. Sperm looks like a tadpole. In the head is the DNA. When we do ICSI, which we always do in this male factor, we inject one sperm into each egg. If the DNA in that sperm is okay, it might still fertilize the egg and propagate a viable embryo. So it can happen. But bottom line is, you may even need to do something called testicular sperm extraction, where we put a needle into the testicle and aspirate sperm directly from the testicle to try to get at least some to have a better chance. Not that it usually helps, but an AMH of this, or FSH of that level is very high and is a call to action immediately. You're not going to reverse it, I'm going to tell you now. Nothing you do is going to reverse that FSH.
A commenter said, I'm 45, done 6 IVF treatment, AMH is 11.2 and AFC of 8. What can I do? Question mark.
At 45, only about 1 in 20 eggs are going to be normal. But if that normal egg is harvested and we fertilize that egg and make an embryo that is chromosomally normal by PGTA, you have as good a chance virtually as you would have had 15 years ago. So it's really important not to waste time if you want to try to use your own eggs. And by the way, I'm assuming that your AMH of 11 is 11 picomoles per liter, and you can comment over there if I'm right, because 11 would be very high in American units, which are in nanograms per milliliter, and 11 is not that low. It's amazingly high for you. So you may still be able to get good quality eggs, or not, you may still be able to get eggs. Whether they're good quality will depend upon the protocol used for ovarian stimulation, how quickly we do it and implement it, and will depend upon the method we use to stimulate you. So I'd be interested to know whether I'm right, and that you are from Canada or the United Kingdom or somewhere in Australia, where they measure the AMH in picomoles, PMOL/L, picomoles per liter.
To answer Bloomweek on TikTok, they said 35 years old, miscarriage 10 years ago. I have 3 fibroids, many fibroadenomas.
Fibroadenomas.
Yes, that's the word. And microprolactinoma.
Microprolactinoma.
That's the word. And is IVF safe is your question.
It is safe. The microprolactinoma needs to be addressed. Obviously, you've had an MRI to pick it up, and they put you on a cabergoline probably or something to suppress your prolactin. You don't need surgery for microprolactinoma, but you keep the prolactin below 20 nanograms per milliliter, keep it at that level, and then you can do IVF, no question.
Izamar on TikTok says 36 years old, AMH 0.75. The high dose of stims was too high, and now my REI want to do minimal stimulation.
Oh my God.
Any advice?
I am so glad you asked this question, and I hope everybody else is listening. I took some time in the beginning to explain that women who've got diminished ovarian reserve or are older usually have an overactive pituitary gland, which is a cherry-like structure at the base of the brain, located just above the roof of the mouth. It produces FSH and LH. So if you are older or you've got diminished reserve, you have usually got high LH, or you've got high biological activity of whatever LH you're producing, which means that your ovary is likely overproducing testosterone. And if that happens, there's an increased likelihood that you will develop premature luteinization. So think about it. If you do nothing to bring your LH level down, to control exposure to overexposure to LH-induced testosterone by doing a natural cycle, what makes you think that your eggs have got a better chance than they had when you did nothing? It's no better chance. So doing nothing, in my opinion, is as good if you've got open tubes and you've got this problem as natural cycle IVF or mini IVF, where they do the same thing but often give you a drug called Clomid or letrozole to start with, thinking it's an oral fertility drug, so it's not going to be able to be not as stressful on your ovaries. Wrong. Letrozole and clomiphene expunge LH out of the pituitary. So even with them, in the hope of trying to get more follicles, which you will get by that mini stimulation approach, you'll overproduce LH and you'll have increased LH-induced testosterone and you'll end up with premature luteinization, in my opinion. So again, it's even worse, in my opinion, than doing natural cycle IVF. Does it work sometimes? Of course it works sometimes. You've heard of women even in their 50s suddenly finding out they're pregnant on their own. Anything can happen. Nature is amazing. But you can't rest on the outside possibility that you may get pregnant, and the chances of pregnancy with mini IVF or with mini stimulation or natural cycle is very much lower than it would be when you stimulate it properly, as I've indicated, using an agonist-antagonist conversion protocol. I use a simple analogy. If getting a woman stimulated is analogous to picking up a weight on the floor and you bend to pick it up, I ask you a question: if it's a heavier weight, will you pick it up with less effort or will you use more exertion? You'll use more. It's the same with stimulation. The more eggs you get, while you protect those eggs against the adverse effects of overexposure to LH-induced testosterone and premature luteinization, the better off you are, and the sooner you do it, the better. I strongly urge us to talk. Again, go to my bio, click on that link that gets you the questionnaire, fill it in, get in line, and let's talk about this, because I don't want to see you go through this thinking you're doing something more gentle and that it's going to be better for you. People often say if you use less, if you give too much fertility drugs, it's got an adverse effect on the follicle, on the egg. Let me correct you. The follicles, the eggs, have what we call receptors on the cell surface. They're like keyholes in the door. The right key has to go into the lock to open the door. The keys that go into the receptors on the surface of the cells, and there are hundreds of thousands of them, are the hormones, the FSH, that causes the cell to do the things it needs to do to develop. So if you end up with all the receptors being occupied, whatever you give in excess thereof will pass through your body, usually out through the urine, and you will never be hyperstimulated. The only risk of giving too much fertility drug is not the stress on the egg, because there are fewer receptors if you have diminished ovarian reserve, so you're not going to get too many receptors occupied. The risk comes if you're one of those women with PMOS, that you're born with too many follicles, too many receptors, and now you overstimulate too many of them. Then you're at risk, but not someone with diminished ovarian reserve. You can use 20 times the dosage of fertility drug that you need, and whatever is not used will pass right through your system without the effect, and you still get the benefit of the maximum exposure. I hope that is understandable, but...
This comment here says, can someone with adenomyosis get pregnant, and if so, how? Question mark.
Most people with adenomyosis I've had many babies. I'm married to one. We have 4 kids and my wife had severe adenomyosis. Adenomyosis doesn't prevent a pregnancy from implanting unless the growing of the adenomyosis into the wall of the uterus constricts the blood vessels that carry the estrogen through the wall of the uterus to the lining to build the lining. And if you could just ask them to turn that down. If you've got adenomyosis and it's constricted the blood vessels, then you'll have a thin lining, and that thin lining will reduce the likelihood of the embryo attaching.
Zara Yazin, thank you for the gifts there. Thank you so much. We'll answer your question in just a
So
second.
it's only adenomyosis with a thin lining that will cause problems with fertility. If the lining is thick enough, it won't.
Alright. Zara on TikTok here says, I'm 37, 2 miscarriages, 1 ectopic, right tube removed, AMH 1.94, 2 years not able to conceive, need help. Also, Zara, thank you for the gifts.
You've got a tubal problem in all likelihood because ectopic pregnancy is almost always the result of abnormality inside the tube, which usually results from previous infections, chlamydia or gonorrhea. And what you've got to understand is you don't have to have the tube blocked. You don't have to have adhesions all around the tubes to cause a problem. The very sophisticated inner lining of the tube can be disrupted from the infection. And here's the good news, or the bad news. If you've had infection, which is likely the reason you had the ectopic, which caused the embryo to get stuck in the tube, both tubes have been affected, even if the other tube is open. It's not just having an open tube that's necessary to get pregnant. It's got to be functional with all the cells in their sophisticated complexities that can function in an orderly fashion. So if the tube is open on the other side, doesn't mean it wasn't damaged. And here's the news. Infection of the tubes is bilateral. Almost always both tubes have been affected. So that if you had an ectopic in one tube, the likelihood is that the other tube has been also affected. It also means that if you were to get pregnant, your chance of having another ectopic is 8 to 10 times greater. And ectopics are not a joke. You need IVF, in my opinion, for that reason.
I'm going to answer user 93 on TikTok. They said, can you get pregnant natural with endometriosis and adenomyosis? I think is what they meant to say, adenomyosis. Or do you need IVF?
We address the issue of the adenomyosis. If you've got a thick enough lining at the time of ovulation and it's over 8 millimeters thick with a trilaminar appearance, the adenomyosis is not going to prevent you getting pregnant. But the endometriosis will cause infertility in most cases. I wrote an entire article on this, which I'll be happy to send you if we talk. I wrote it and presented it in one of my presentations a few weeks ago on endometriosis. I believe we had a response of over 30,000 people that responded to one of the articles that I wrote on endometriosis. So when you get to that article on YouTube, or you go onto Spotify, or you go onto Google, or onto Amazon, or just go to Dr. Geoffrey Sher and read up on it, you'll understand that at endometriosis, even before you can see it through a laparoscope, even before it's visible, you will have toxic pelvic factors that make it hard for an egg leaving the ovary to arrive at the tube in a condition capable of being easily fertilized. That is why, even before you know you've got endometriosis, but you're headed in that direction, often before you get it, if a doctor's done a laparoscopy, you'll see nothing and say your infertility is unexplained, and then you come back 5 years later, they repeat it and they find you've got endometriosis. So the truth of the matter is, even before it's visible, it's preclinical. It is causing this toxic pelvic environment that prevents eggs from fertilizing, and your chances of getting pregnant are markedly diminished, 6 times lower than normal. At the age of 33, 34, the chance of having a baby per month of crying is about 15%. The chance in a year is about 60 to 70%. With women with endometriosis, perfectly open tubes, no adhesions in the pelvis, but only very early or preclinical endometriosis. The comparable chance of success is less than 2% per month, and the chance of having a baby in 4 or 5 years is going to be about 40%. And you can't afford to sit around and wait. There's only one way to bypass that. IVF bypasses the toxic pelvic environment. Even if there's no immunologic problem that I discussed earlier on, you can't sit around waiting to try and get pregnant. If you do IUI or you do surgery to get rid of the endometriosis, which as I alluded to earlier is no longer necessary, you will not improve the chances, because for every little endometriotic deposit that's present, there's probably another 20 coming up, and it keeps on developing. No matter what you remove, it comes back. It's a gift that keeps on giving.
I'm going to answer Eileen here on TikTok. They said, premature ovarian failure, diagnosed at 21, now 31. What can I do to improve my chances? ?
Well, if you've got premature ovarian failure, it means that you've gone probably into premature menopause. And at that stage, which we can try, but there's likely very little that can be done. Now, in your case, it may be worth trying because you're young. And remember what I told you, age has a direct effect on the quality of the eggs, whatever eggs are in your ovaries and remaining, because over time, through wear and tear, the eggs get corrupted. So if there are any eggs in the ovaries, and we can awaken it using a very individualized protocol. I mentioned the AACP, the agonist-antagonist conversion protocol, and in your case, with estrogen priming used, and we can even make 1 or 2 eggs. At the age of 30, there's about a 3 in 4 chance that that egg would still be normal, even if only 1 follicle was made. So it's worth trying, but it's a very long shot since you're probably so far along on the curve with that problem already. You may not produce any eggs, which is likely to be the case. Again, we should talk. You don't have any time, any wiggle room. So try and arrange to fill in that questionnaire so we can discuss it.
Again, that questionnaire can be found and located in the link in our bio. There's about 30 minutes left of today's session, a little bit less, that you guys can get access to the exclusive article that Dr. Sher wrote on today's topic. The link is in our bio. You guys can go check it out. You fill out a 4-minute questionnaire and you get access to literally everything in there. So go check it out. Everything's there for you. We're going to answer a few more questions with our time remaining. Please keep commenting. We're going to answer as many as we can today. But if we don't, feel free to DM us. We've got a very large team that will reach out to you and give you a specific answer to whatever your question is, and set you up with a one-on-one discussion with Dr. Sher if needed. The UK, I'm going to answer your question here. It says, does my height, BMI, and sedentary life affect high FSH as a man? What test is next? ? I'm 28, scared.
Have your FSH, LH, testosterone, prolactin, TSH, and semen analysis done. That'll give you an answer.
Awesome, UK. Let us know if that's good for you, and if you have any more questions.
I'll repeat that. FSH, LH, testosterone, prolactin, TSH, and semen analysis.
Awesome. Like I said, UK, if you have any more questions, please feel free to DM us or fill out the questionnaire and have a one-on-one discussion with Dr. Sher. I'm going to answer some more questions here. We're going to go down here. Ralto says, is it better to transfer 1 egg or 2 during a transfer?
Well, in the old days, before we did PGTA, we'd put in quite comfortably up to 2. The pregnancy twin rate was about 30%. Today, it's not a good idea to put back 2 PGTA normal embryos into a receptive uterus because you're going to get double that pregnancy rate of twins. Twins may sound like a cute idea. It's not cute for the baby that's usually going to be born a little prematurely, a little earlier than normal, and the earlier a baby's born, the more the hazards. Its organs aren't usually, especially the lungs, fully ready for the outside world. So it's not a good idea to have twins if you can avoid it. So if we put in PGTA embryos and put 1 embryo in, and we do it and transfer it into a receptive uterus that we've made sure does not have an anatomical or an immunologic impediment to implantation, and the doctor doing the transfer is a good gardener who knows how to plant the seed in the uterus, knows how to support the soil, the uterine lining that you're planting it into, and knows exactly how to do it efficiently, your chance of being successful is very good. So it's really important to keep those factors in mind.
All right, I see more push notifications coming through for the books. I thank you guys so much if you're filling that out. You guys can go fill out the link in our form, or the form in our link in our bio while you're watching and listening. It doesn't take much time. It takes about 4 minutes of your time. Fill out that questionnaire and get access to everything. And you can continue to listen to us and answering questions here. I want to answer Ismar on TikTok. It says 36 years old. AMH is 0.75. LH is 3.6. Baseline.
Did you say AMH?
AMH 0.75, LH 3.6 baseline in March 2026, now is 3.4 in July 2026 before stims.
What's 3.4?
I believe that's the baseline, LH, 36 baseline, and then 34.
Something doesn't make sense here.
3.6 baseline and then 3.4.
Your lowish AMH suggests that your FSH should be much higher, unless you had a cyst or your estrogen level was very high. Either way, the AMH suggests that you're running out of some time here and you need to move very quickly. Again, the protocol of stimulation is central to your chance of success. Don't think that using any old approach is going to work. It's fine for a doctor to use a recipe approach. You don't want a recipe approach, and you do not want, not only do you not want a recipe approach, you also want to have a very clear understanding of what the protocol is that you're going to be on.
Jamie says, I live in Florida. Can I work with you still?
Of course. My patients come from 72 different countries, from all over the world. So I urge you, go and fill that in. Let's talk. I have so many people in Florida, you have no idea. I probably at this moment have 7 or 8 people going through with us right now from Florida. It's very easy. You only have to be prepared to spend less than a week in New York. All the preliminary testing, all the preparation and everything we do is based upon working with you and your doctor at a distance, and you will end up being monitored in New York for the last few days, having the egg retrieval. We have patients who come to us from all over the world. As I said, 72 different countries. Abu Dhabi, Hong Kong, Tokyo, Shanghai, Beijing, Moscow, all over.
Awesome. I'm going to answer, also thank you TS9 and Vanny for the gifts here. I see you guys here both gifting us. I'm going to answer you guys' question in just a second here. TS9 said, tried for 4 years for my son. Been trying for 9 years. I'm 36 years old. What can I do? ?
There's a reason it took so long with your son, and you know what one of the common likeliest reasons are? And just tell me if I'm right. Give me a hint. The commonest cause of this is endometriosis. That you were lucky to get pregnant with your son because a good egg crossed over through the valley of the shadow of fertilization, which is like crossing a river with piranha fish where the toxins in the pelvis got through and made your beautiful son. But that doesn't mean it's more likely to occur next time. So now you're sitting with secondary infertility. That is one of the common reasons. Another common reason is an immunologic problem linked to alloimmune, ALLOIMMUNE, implantation dysfunction, which also often results in a woman having one baby and then not able to get pregnant later. So I suggest you get to my books. Buy the free handout. All you do is go to the bio, click on the link. You'll get the books. Read up in the books, in the thin book, the one on immunology, the first 2 chapters, and you'll understand why it's one of the common causes, immunologic, alloimmune implantation dysfunction. It's one of the common causes of secondary infertility. But those 2 things, endometriosis, and which is the most likely, and the other one, alloimmune implantation dysfunction, are the 2 likeliest explanations. And I can help you with those if we talk. Again, to do that, you need to fill in that questionnaire. And again, you're not under any pressure. No one's going to solicit you. This is only to get you in line so we don't disappoint you. So go ahead, get in line, fill in that questionnaire. It'll take you 5 minutes. Do it right now. And Patty will get back to you and we'll talk.
Perfect. We're going to answer Vanny here. Also, thank you for the gift. It says, do you do hospital-based retrievals for high anesthesia risk?
No, there's never been a need because we don't use general anesthesia. We use conscious sedation with propofol usually. And all of them are done in our clinic setting with an anesthesiologist and the doctors on standby, where we have all the facilities available to deal with emergencies if we have to.
Awesome. TS9, thank you for the more gifts. We really appreciate it. Hopefully we answered your question today. I'm going to answer Roxana Borza on TikTok. It says, I am 31, AMH 0.16 with endo and adeno. Still have a chance, ? Should I do IVF, ?
Funnily enough, IVF's all you've got is a hope. Because your age is young, approximately 2 in 3 of every one of the eggs we get from you will be normal. If you had been 45, only 1 in 40 would be normal. That means you would have had no chance. But with you, even though your AMH is low, if we use the right AACP protocol, possibly with estrogen priming, we'll still get at least one, hopefully, normal embryo. Maybe not the first go round, but 2 out of 3 should be normal if we keep the LH-induced testosterone production at bay by using that individualized approach that I spoke about and that you'll read up in the article that I gave you, and also that you'll find in one of these books that I'm sending to you and recently written as free downloadable ebooks by going and clicking on the link. Click on both links, the one that gets the books and the article and the one that gets you the questionnaire to get you in line so we can talk. This is too important to let it lie. We need to really get down to business and discuss things.
Alrighty, I'm going to answer some more questions here, but as Dr. Sher said, all our resources are in the bio, in our link in the bio. You guys can go check it out. We have about 20-ish minutes left of today's session for you to get access to the exclusive article. The books will still be there anytime during the week. You guys can go fill out the form, check the links in bio. All of that will still be there. You just will not get today's exclusive article that Dr. Sher wrote. The articles are always written the day before or during the week of for this exclusive live session. He writes them for you guys exclusively. They can be anywhere from a couple pages to 20 pages. And he puts a lot of detail, time, and effort into them. So go check that out. That is in the bio. I see a bunch of push notifications coming through for overall today. So I'm so excited everyone has that access. Anybody who's in the live chat right now actively gets access to it. So go check it out. I don't know why you wouldn't. It's free information and you can have it at any time. And share it with anybody you want. You're free to share the links. Share it with anybody else that's in these situations. We're going to continue answering some questions. There's so many, so thank you guys all. If you have not had your question answered, please send us a DM or click the link in our bio and we'll have a one-on-one conversation with you. We've got a very large team, so we will respond to all DMs. I'm going to answer some more questions here. Stop at the loop. Val on TikTok says, with DOR, have you ever seen cycles stop after Lupron flare? ?
Have I ever seen cycles what?
Cycles stop after a Lupron flare.
Of course, it can happen. Because with a Lupron flare, in women with severe DOR, there's the increased production of LH, and that can send testosterone flushing into the follicles, and that can cause such severe premature luteinization that a cycle can be cancelled because the follicles and eggs arrest in development. If you use the right protocol, as I explained with the AACP, and you start the Lupron a week or 10 days earlier, you don't get that effect. And you protect the eggs.
UK says every hormone was normal except for FSH22, total T200, free T60, no semen analysis yet.
I did hear.
So, UK, that's the person who
yes.
They asked, every hormone was normal except for FSH22. Total is T200, free T60, no semen analysis yet.
Okay, let me explain. The testicles have got 2 compartments. An area called the Sertoli area, Sertoli, and another area called the Leydig area. The Leydig area produces testosterone and responds to LH. The Sertoli area responds primarily to FSH. So if the FSH is high and there's still not adequate, and the FSH is still high, it's telling you that the Sertoli cells are not responding unless there's plenty of sperm. So if your sperm is low and your FSH is high, it means that the whip cracker, the pituitary gland, the mule driver, is cracking the whip louder to try to make the Sertoli cells produce sperm, but they're not doing it in spite of high levels of FSH. And that can explain the cause of your male-related factor. So if the FSH is high, one of the serious concerns is that the pituitary is trying to make your Sertoli cells produce more sperm because they're not doing a good enough job. Really important to check the semen analysis after a few days of abstinence and correlate the two and then get back to me. I'll be happy to help you and advise you. And by the way, let me just mention again, you can have perfectly normal testosterone through the Leydig area producing adequate testosterone from LH and still have a Sertoli cell problem.
UK says, thank you, I love you, Doc. We're going to go over to here. Safe Haven on TikTok just gave us a gift, so thank you so much. They said, please, can you recommend how to improve decreased AMH levels?
Is no way. There is no way. You've got to make use of what you've got, make hay while the sun shines, which means be proactive, be reactive, be quick in moving fast, because things are only going to get worse. Now, they may go up slightly and down, but the way they go down isn't just like that. They go like this. So you catch them on the upswing or downswing. The overall trend is down. Do not waste any time.
All right, I'm going to answer this question here. Amlock84 on TikTok says, I have 7 kids, pregnant and 41. Will have DOR later. I think they meant to say, will I have DOR later?
Everybody will get DOR eventually, as they run out of eggs.
Safe Haven, thank you for the gifts.
But you're quite a lady. All those babies. Good luck to you. Wow, you're brave.
Someone earlier commented, they asked if you had 17,000 babies, because our title at the top says that
17,000, close to 18,000.
But they thought they were your personal. That was the comment. Is they said 17,000 babies of his.
I've been married all my life to the same woman, and she.
Genghis Khan over here.
Yeah.
All right, we're going to answer some more questions here. Thank you guys for all these questions. These are great questions. Thank you all for commenting. I'm going to answer Safe Haven really quick here because she just sent a good question. It says, where are you located? Dr. Sher, where are you located and how can people talk to you?
All my consultations are done online. I am in Vegas and in New York. I do most of all my consultations online. It's really important that you set that up through Patty. What she'll do is you'll fill in the questionnaire. She will basically arrange a time for you and I to be online together. By that time, I'll have spent an hour already on your case building a template. We'll talk, I'll fill in the gaps by getting extra information from you. And if I need additional information that you can provide on the spot, I'll ask you to get it for me and send it to me and we'll pick up again. That second consultation will be at no extra cost because the first consultation is the one where the insurance picks up on it. All right, so then what happens is we talk, I write you a letter which is usually between 20 and 30 pages long. The report is in the central portion clinically. On either side of that report you get additional information. The front end, I send you again the books that you can get here, articles that you might need, and I give you information on how to access me anytime you need. I give you my personal cell phone number so that you can call me anytime you like. You're never bothering me. I'm always available and I'm always going to respond. You don't want to email or text me because I can't answer your questions in one-line answers. You call, if I'm busy, you leave your name on the phone. I call you right back as soon as I pick it up, and it's a free consult. And then what happens is you make up your own mind as to what you want to do. If you choose that you want to go through us, I then have you talk to my partner, Dr. Drew Tortoriello in New York. No one doctor can treat a patient with IVF because there's too much going on, and nobody can be available all of the time. And because we've worked together for 20 years, we are like two peas apart. We do things identically, and so when you speak with him, speak with me, it's one voice. We interact. I give you all the advice because you remain my patient. He and I together manage your case. You then talk with him, and if you need treatment with us, like people from all over the world, from more than 70 countries, you end up coming to New York for less than a week to get treated. The preliminary treatment and preparation is all done at home by your own doctor interacting with us, and we orchestrate all that. You come in, we do the egg retrieval, we check your uterus, we check your eggs, we check your husband, we make the embryos, take them to blastocysts, stay in touch with you throughout the process as to things going on. And then we will be talking when we get the results back from any tests done on the embryos. And then we plan and discuss how to proceed. Some women will say, I've been waiting so long, I just want to go ahead and do a transfer and get pregnant as quickly as possible. If I have a euploid embryo, chromosomally normal. Others will be wiser and they'll say, look, I want to make hay while the sun shines. I know time's running out. Hang on to the embryos and bank them and stockpile them for me so that I have options and choices down the line. There's so much more to discuss. All these things we will discuss during our online consultation.
Perfect. Lotus Moves asked, how can I start ovulating? Never been pregnant at 39. They also asked if CoQ10 and D3 are good for ovulation.
They're very good, but they're not good for ovulation. They're good for your overall health. To what extent and whether they help, it's hard to say. It's hard to say which of these things help. The only thing I try to avoid recommending, although others will differ and people are entitled to their opinion, I tell my patients not to use DHEA, dihydroepiandrosterone, because it's a precursor of the male hormone testosterone. And if you take it, in my opinion, women that are older have diminished ovarian reserve, and women who've got PMOS are better off not using it because it goes to the ovary, converts to testosterone in the ovary, and it can make matters worse for the eggs. So I don't like my patients using DHEA. But other than that, the others, some of them work. The Chinese herbs, maybe they work, I don't know. The ones that are probably the most popular are CoQ10, folic acid, vitamin D3, vitamin B3, vitamin B6, and also prenatal vitamins, and pycnogenol. There are a couple more. Those are all good things to use. You use those. That's about it. I can send you an article that I wrote on nutritional supplements in IVF. All you have to do is ask me when we speak, and I will make sure that I send it to you.
Perfect. Erica on TikTok says, benefits of testosterone gel for ER protocol, 40 plus.
0, in my opinion. Because if you use testosterone gel, it gets absorbed, goes to the ovaries, and increases the problems for the eggs trying to develop. Too much testosterone is not the thing you want over 40. You're already making enough of your own in the ovaries.
Perfect. I'm going to go
Increases
back
the risk of premature luteinization.
Alrighty, we've got about 5 minutes left of today's live stream, guys. So if you haven't already, after all of us talking so many times about it, go check the link in bio. There is free books, free articles, and an exclusive article for you guys today based on today's topic. If you've been in here for a minute now, I don't see why you haven't gone and gotten that. If you've been listening to all the advice that Dr. Sher has been given, all the questions he's been answering, and the amount of information he has that he's willing to give you guys as much as he can, go check out that link in bio. There's even more information on there, and you guys can get even deeper into the topic that you're looking for. It takes 4 minutes of your time, fill out that questionnaire, get access to everything that's on there for you guys. I'm going to answer a few more questions here while we have the time. Probably going to answer about one more, so comment your favorite question here, the one I see the most. We'll get it answered here, so give it a couple seconds.
One more now, I want to say a few words.
Absolutely, yeah. Get one more question, guys. We'll let it spam for a second, and then the comment I see the most we'll answer here. Give you guys a second. I see it's a little bit between UK and Val right now. All right, I think I'm going to answer UK because they've got a lot of questions today. Follow-up question number 1. It says, is it possible with a high FSH I can have compensated spermatogenesis? Did I say that right?
Spermatogenesis. But with a high F, it's the same person again?
Yeah.
What does he want to know?
Let me
Is
go
it
back.
possible?
So it's follow-up question number 1. Is it possible with a high FSH I can have compensated spermatogenesis?
It is possible, and you don't need a lot of sperm. We can do ICSI. We can identify which are the good sperm by doing a procedure called Zymot. We can actually do Pixie and Zymot, pick out the best sperm, inject with that sperm, and you can still have a baby. I had a general who came to me from Fort Bragg. He had to go back into the ejaculation room 6 times, and all we got out of him were 13 sperm. Can you believe it? And we did IVF with ICSI on him using those sperm, and his wife had twins. So it's not all about count, it's about quality. And it's still possible, and if you can't get the sperm in the ejaculate, you can do a testicular sperm extraction, or TESI, and all of that's in the book. Read it in the book. Go to that thick book of mine that I give you as a downloadable ebook, and read up on testicular sperm extraction.
All right. Last question, because I see several people asking for it. They said, how much is a consultation, and do you accept insurance? Are the 2 questions coming up.
Virtually everybody we speak to has insurance if they come from the United States, and we accept it as complete payment. So there's nothing out of pocket if there's insurance. If there's no insurance, I'm sure I don't even know the exact cost. I'm not sure. It's somewhere between $250 and $500. I don't know, but when you speak to Patty, there's no one I'm talking to. Patty's the sweetest. She happens to be a horse whisperer. She's got a ranch with horses that follow her around like dogs follow their master. She's just the sweetest, kindest, most loving person. People like her a lot more than they like me. And I don't blame them for that, because I do too. Patty is great. She will give you all the information. She'll give you ways in which you can finance it if you don't have. She'll be there for you and nag you and come back and forth to you if you wanted to. If you don't, she won't engage. So I suggest you fill it in, speak to Patty, ask her the questions, but we have a very good system here where we accept insurance payments.
I just want to read this comment here. This is funny. It says, UK, the person we've been answering, says, I will name my son after Dr. Sher. This is the final comment. But Dr. Sher, feel free to take us out. We are...
Okay, I just want to say how grateful I am to all of you. We are growing in leaps and bounds. The number of followers we've got is increasing in every forum. And when we get to a certain critical point, I'm basically going to launch a podcast. And then I'll start bringing in people, and I know them all over the world, online, to do live podcast participation, where we can give you up-to-date information from real experts in different areas. I really appreciate your participation. I've only got one closing request. Many of you are in chat rooms. Many of you are in groups already where you discuss infertility. Tell them about our podcast, our webinars every Saturday. There'll be one next Saturday, and then the following week it'll be on Thursday the 6th at 4:30 p.m. West Coast time and 7:30 East Coast time. I ask you to please get the word out there. Tell people to come and join our party. I love it. I'm enjoying it. I love speaking to all of you, and I only hope that I'm doing you some good.
Awesome. I'm going to give it...
The goal here is simple. Educate and inspire. Perfect. If I can do those 2 things, mission accomplished.
Beautiful. I'm going to give it like 1 more minute. Anybody who's still in the chat right now, please go check out the link in bio. I won't take off the link there for another few minutes to give you guys all some time to fill out that questionnaire and get access to everything. But in about a couple minutes after we end this live stream, which is in about 2 minutes here, or a minute and a half here, I'm going to end the live stream. You guys will have about 5 minutes to go get that link, get everything accessed. So go do it while you can. There's so much free articles and free information in there that you just won't be able to get anywhere else. And if you've been here this whole time and seen how much information Dr. Sher has brain dumped on everybody today and every week, there's so much information here that there's no reason why you shouldn't go get that. It's all free.
There's not enough said about What a great job Josh does as the
Thank you.
videographer. I love working with Josh. And when I'm lucky, he brings his beautiful partner with him. And she's a great asset. I also want to mention Jude Borenstein, who also works with Josh
Yes, sir.
as a videographer. He's leaving for Spain on Sunday. Be away for a couple of weeks. We wish him well. He also does a great job. And thank you all once again for participating.
Thank you. We'll see you all next week.